So welcome everyone to this month's ERN GUARD-Heart webinar. Nice that you are here with us. Today the topic is cardiac amyloidosis, and we are very happy to have the member team from Paris with us, and our moderator of today is Philippe Charon. Welcome, Philippe. May I give the word to you?
Thank you, Ninke. So welcome to all of you. It's a pleasure to share this webinar about cardiac amyloidosis, which is an issue that has an increasing interest, increasing recognized prevalence, increasing therapeutic resources. So very, very impressive advancement in this area. So we have a couple of experts with us today from Mondor Hospital team, so the team of Professor Thibaut Dany, with the help of Dr. Sylvia Ogina. So we will start now. So I suggest to Sylvia Ogina to start to share the screen with the slide, and you will have a first clinical case and talk more related to the diagnosis issue. Please, Sylvia.
Thank you very much, Professor Charon. I'm really glad to present you indeed this presentation about how to diagnose cardiac amyloidosis and its subtypes. So just a small introduction. Cardiac amyloidosis were thought to be a rare disease in the past. For example, in this 2014 ESC guidelines for hypertrophic cardiomyopathy, amyloidosis was in the part of other genetic and non-genetic causes, representing from 5 to 10% of all hypertrophic cardiomyopathy. In the recent year, with better description and many publications, as you can see in the left part of the slide, has led to a better recognition and more patients with ATTR wild-type cardiomyopathy in the last 20 years. So for the clinical case, it's the case of Mr. C, 75 years old, hospitalized for the first episode of acute heart failure. In his medical history, he was treated always with monotherapy and always controlled for hypertension. He was operated in January 2022 of a bilateral carpal tunnel. He described symptoms of polyneuropathy since 1 year. And the last 6 months, he described spontaneous periorbital purpura. The EKG is this one, with a grade 1 atrioventricular block and a pseudo-ischemic pattern in the anterior and inferior leads. The TT is this one with a biventricular hypertrophic cardiomyopathy with hypertrophy, with 13 millimeters of the septum and the posterior wall, an ejection fraction normal at 76%, but an alterate global longitudinal strain at 13%. So the first question is, in front of this patient with the first episode of acute heart failure, do you have to go further to search cardiomyopathy? The answer is yes, and it's well written in the first and last position paper from the ESC working group on myocardial diseases, published 2 years ago. In case of left ventricular wall thickness above 12 millimeters and some red flags, in our patient we have the heart failure at an age above 65 years old, the polyneuropathy, the skin bruising, the bilateral carpal tunnel, and also echographic pattern evocative of cardiac amyloidosis with the longitudinal strain reduced with apical sparing, and the EKG modification with the pseudo-ischemic pattern and conduction disorders. You have to evocate the diagnosis of cardiac amyloidosis. Just a reminder of the 2 main types of cardiac amyloidosis. The first one is TTR1. The TTR is the protein produced by the liver in the shape of a homotetrameric protein, who can dissociate into monomeric TTR in two situations. The first one is in case of a variant of TTR in the hereditary ATTR, or in case of no mutation when the people get older. The second type is AL amyloidosis, which is due to the excess of production of light chain, most of the time lambda, secondary to a plasma cell dyscrasia, most of the time MGUS, monoclonal gammopathy of unknown significance. The two exams to diagnose cardiac amyloidosis are really simple to do, to perform. The first one is the bone scintigraphy. Here is the bone scintigraphy of our patient, showing a really strong myocardial uptake of the bone tracer. A reminder of the Perugini classification for the myocardial scintigraphy. Grade 0 is the normal one, with no myocardial uptake and normal bone uptake. The grade 1 is when the myocardial uptake is really small, under the degree of bone uptake. Grade 2 in grade 3 allows to make the diagnosis of ATTR in absence of monoclonal gammopathy. Grade 2 is when the bone and myocardial uptake are similar. And grade 3 is when the myocardial uptake is really greater than the bone one. The second part of the diagnosis is to try to detect monoclonal gammopathy by hematologic tests. The first test to perform, and you have to do all the 4 tests to diagnose the monoclonal gammopathy. The first test is electrophoresis, which was normal in our patients. The immunofixation is really important because it will detect M protein under 2 grams per liter. It's the case in our patient with the detection of an IgG lambda. Then you have to perform also the free light chain assay, showing here an excess of lambda light chain. And you have to complete with the urine sample with electrophoresis and immunofixation, showing here the presence of Benjon's lambda. So I remind you that our patient have had some skin bruising, and you have monoclonal gammopathy. It's really frequent to have a periorbital purpura in AL. Could you conclude to AL amyloidosis? Actually, you have to look at the guidelines showing that in the simple case of myocardial fixation uptake on scintigraphy, but without monoclonal gammopathy, you can make the diagnosis of ATTR. But in the cases of AL suspicion, when you have monoclonal gammopathy without fixation at the bone scintigraphy, or if you have a doubt between TTR and AL, if you have myocardial uptake on bone scintigraphy and also monoclonal gammopathy, you have to perform histological confirmation. Why is really important to type correctly the amyloidosis? It's because monoclonal gammopathy is really different from AL. Monoclonal gammopathy is highly prevalent in the aging population. Here you can see that for a patient, a man of 55 years old, it's almost 6% of the population. And the prevalence of MGUS in ATTR histologically proven is even higher, going from 40 to 50% of our patients. And we don't have yet any hematological marker to differentiate AL from TTR with monoclonal gammopathy. So histological typing is really necessary in suspicion of AL or ATTR with monoclonal gammopathy. The first step is to perform the less invasive biopsy, salivary glands most of the times, which will allows you to type the amyloidosis in 70% of the case in TTR and 80% of case in AL. We don't perform in our center abdominal fat and rectal biopsies because of the low sensitivity, which is under the salivary glands one. So in case of, if you don't find any amyloid deposits in salivary glands, you don't have to exclude the diagnosis, but to go directly to the affected organ. Here, the endomyocardial biopsy, but you could also biopsy the kidney, for example, if you have abnormalities of the kidney you saw. For the biopsy, you have to do 2 fragments. The first one included in paraffin for special coloration, for example, Congo red. And the second one will be frozen to perform antibodies specific for TTR, kappa, and lambda to correctly type the amyloidosis. So our patients with perigeny 3 scintigraphy and monoclonal gammopathy had no deposits of amyloidosis in the salivary gland biopsy. So we performed the endomyocardial biopsy, confirming the diagnosis of amyloidosis. The last step of the diagnosis is to perform the genetic testing, which showed in our patients a TTR variant thrombin 60 adenine at an heterozygous state. So our patient had a TTR variant with explaining all his symptoms. So just as a small conclusion, cardiac amyloidosis are effectively increasingly recognized cause of heart failure, but also many phenotypes shown in cardiology, conductive disorders, aortic stenosis, heart failure with preserved ejection fraction. The red flags are really useful to suspect cardiac amyloidosis, but the message of this presentation was that none are specific enough to type cardiac amyloidosis. You can see that in the left part of the slide, which is a part of the AC guidelines on heart failure, that skin bruising is really evocative of AL, but you also have on the right part this case report recently published confirming that some hereditary transthyretin amyloidosis may present with spontaneous periorbital purpura. The algorithm to type cardiac amyloidosis is simple, and in some cases you don't have to perform the biopsy, but once again, the biopsy is really, really important to type AL, and in case of doubt between TTR and AL, you have to type correctly the amyloidosis. And the last thing, and it's a transition to the presentation of Thibaut, cardiac amyloidosis were once considered untreatable. It's not the case anymore. Now we have effective treatment for this disease. Thank you for your attention.
Thank you very much, Sylvia, for this great talk. Are there any questions? Please do not hesitate to put your questions in the chat and ask some information or comments to the expert. I have one question. Can you remind us the prevalence of cardiac amyloidosis according to the entry point, for example, heart failure with preserved ejection fraction and so on, according to age, possibly? Can you put some figures about the prevalence?
It's about 20% of heart failure with preserved ejection fraction. A recent paper showed that it's also 12% of patients with heart failure above 65 years old. We also have a link with aortic stenosis. About 15 to 20% of aortic stenosis have cardiac amyloidosis, and also recently linked showed with mitral regurgitation. About 8% of the patients who were operated of mitral clip have also cardiac amyloidosis.
Thank you. So we should think more and more about this disease. Regarding genetic testing, sometimes colleagues ask us, it is necessary to perform genetic testing when there are some patients that are quite old. So what would you say to answer this question?
I can say that our oldest patient with hereditary TTR was 83 years old at the age of the diagnosis. So it's really important to perform the genetic testing, whatever the age of the patient. We have almost 20 patients above 85 years old with hereditary TTR. So it's really important for the family.
Okay, thanks. And there is one question about the role of CMR as compared to nuclear testing. So what would you say?
The CMR is at the level of the TT. It's a really good exam to raise the suspicion of cardiac amyloidosis, but it's not an exam who will confirm and type the amyloidosis. So it's important to perform the exam, but I think you don't have to waste your time with the CMR for the typing of the amyloidosis. You don't have to delay the diagnosis for the CMR.
We agree. The sensitivity, specificity is absolutely different, yes. So I think we can move on, and you will have also the possibility to continue to ask questions at the end. But now it's my pleasure to introduce Thibaut, who will teach us about the management of this disease. Thibaut, please.
Okay, thank you, Philippe. Hello, everybody. Oh, sorry. I don't know why I'm not at the first slide. Here we are. Okay, so it's a pleasure to be here and to have the opportunity to share our knowledge on cardiac amyloidosis. So I will focus on transthyretin amyloidosis, as we have, as the clinical case was about TTR amyloidosis, and that we don't have a lot of time to speak about all the aspects of this treatment. So, of course, everything is in this consensus papers that summarize really the how to take care of these patients. And I really recommend to have a view to this paper. So just if we go back to the physiopathology of the disease, I have just a few important things to share with you. Is first that we need to understand really the pathophysiological mechanisms involved in this disease. First, we have to understand that it is a dynamic disease, which means that the way the fibrils infiltrate the heart is dynamic, and that the fibrils are replicate themselves, and the number of fibrils is increasing. That explaining was there is already it's important to understand that the heart failure is going worse and worse with the time, and we need to stop this process of fibrils multiplication to have an opportunity to save the patient. So when we look at this patient and the natural history of this patient with TTR and eventually, of course, AL amyloidosis, what we are seeing is that this patient aggravates during time very rapidly, but the speed of aggravation is really dependent of the onset of the disease and where you are in the disease, which means that if you are at the beginning of the early process of the replication and the infiltration, you can really, by the treatment that we have, we will see that stabilize the disease, stop the disease. But this kinetics increase as every fibril is multiplied by themselves. It's an exponential way of multiplication of the fibrils, and you have to understand that it's really dependent where you are at the history of the disease and when do you start the treatment. So as Sylvia explained us, we need to do the diagnosis as early as possible to start the treatment here at the beginning of the story and then at the end, but because of course the impact actually with the treatment that we have will arrive too late. So still go back on these guidelines. So I will speak particularly on disease modifying treatment, because I can't talk about everything in the time that we have. But of course, I will reply to other questions if you have. So if you look at the different opportunity to treat these patients, there are also these nice guidelines. Just to go back to the explanation of the pathophysiological mechanisms of the production of the TTR fibrils. Everything starts at the level of the liver. The liver is producing the transthyretin protein, and for transthyretin protein is going to to create the tetramer of transthyretin, which is a transporter of the thyroid hormones and the retinol. So what's happening in this disease is that when the tetramer is not stabilized by himself or due to a genetic mutation in the hereditary pattern, you have a destabilization of the tetramer and the production of amyloid fibrils. So the treatment that are developed was first liver transplant to change the type of proteins produced in patients only with hereditary transthyretin. And now we moved by the creation of genetic silencers that can stop the production of transthyretin. But there is a way also to stop this destabilization of a tetramer, is to stabilize it. And you know that we have now a drug that is available, Tafamidis, to stabilize this tetramer, and we will go back from the data that we have. But there are also a lot of hopes coming, and particularly to try at we hope that it will work, of course, to decrease the amount of amyloid deposit using antibodies, and there are several antibodies developed. So if we go back at this pathophysiology, so you have the possibility to stop the production of transthyretin by different type of acRNA, anti-oligonucleotide, CRISPR-Cas9, we will go back. Liver transplant only for hereditary patients, but now most of the patients are treated by these drugs, stabilize the transthyretin tetramer or remove it. So now what do we have and what is recommended in patients by the say recommendation? So the only treatment that we can have as cardiologists is Tafamidis, the stabilizer of tetramer, as you see is a class 1B of recommendation. And Tafamidis has shown his interest by decreasing the amount of death and improving the survival of 30 months in patients that have hereditary ATTR amyloidosis or wild type of amyloidosis. And we know that it has a great impact also in stopping the decrease of 6 minutes walk text distance, and also stopping the decrease that we observe in quality of life in this patient. Just see that this is a natural history of a disease, and also you have a great amount of patients that are going to die, but they are going to alter their quality of life really, and that Tafamidis is able to stop the progression. So we know also what is the dosage is now used. We have different dosage. Our neurologist colleagues are able to prescribe 20 milligrams, and ATTRACT demonstrate that 80 milligrams do better in terms of T. That's why that we have this dosage in cardiology, and that the company that developed this treatment developed 61 milligrams, which is an equivalent of 4 pills of 20 milligrams. And what we have now, new data with a longer follow-up that show that Tafamidis, of course, is able to improve the survival, but even in patients that are treated lately, and it was a placebo group, you see that the curves is changing. But of course, if we treat the patients earlier, we can really improve the diagnosis and their prognosis and quality of life. And this is a paper published by Sylvia about the patient of our cohort in real life. So it was what we were facing before Tafamidis. This is the patient that are in NTproBNP class more than 3,000 or less than 3,000. So it was at the time of baseline, at the time of diagnosis. And you see in our center that before Tafamidis, 18 months after the diagnosis, nearly 45% of the patients were dead, and most of the patients had NTproBNP, the remaining that were alive, increased above 3,000. After Tafamidis, we improved the diagnosis, and more patients were diagnosed with less NTproBNP, less than 3,000, but you still have a large amount of patients with more than 3,000, and you can see that the amount of patients that survive has improved, as only 17% of the patients died, and that most of the patients remain above 3,000. So Tafamidis is able really to stabilize the disease, and it has been shown also by the Boston team on echocardiography that showed that the decrease observed in LV strain is partially stopped in patients that are treated by Tafamidis. We have also some other data coming from the Australian teams showing that Tafamidis is able to stop the increase in LV wall thickness and also to stop the decrease of LV strain and LV systolic function. Here is a study on bone scintigraphy, and you see that after Tafamidis treatment, most of the patients have a decrease of the cardiac fixation due to this treatment. So there is a decrease even by maybe a reabsorption of amyloid fibrils in the heart. So there are other treatments, of course, that has been developed, and we have neurologic colleagues have worked for a long time about this disease in patients with hereditary transthyretin amyloidosis, and these patients have mostly this phenotype, neurologic phenotype, and most of the patients have a Portuguese mutation that is called ATTR valve ultimate mutation. And we know that patisiran, this drug developed in Apollo trial, is able to improve, to decrease, of course, the level of production of transthyretin nearly by 80 to 90%. Also to improve the MNI scale, which is a neurology scale to evaluate the progression of a neuropathy. And we see here that even this treatment is able to improve the neurologic part of the neurologic symptom of the patients. Of course, patients with hereditary transthyretin with neurologic mutation. So we published also a cardiac sub-study regarding this patient with a neurologic ATTR mutation. And what we observed, it's a post-hoc analysis that patisiran was able to stop the increase in NTproBNP, has some impact also effect on increase in interventricular septal thickness, even in LV strain and 6-minute walk test. That's why the company developed another study on a patient with cardiac amyloidosis, both amyloid wild type, ATTR wild type, and hereditary, but at this time with cardiac mutation. And so this study recently was completed for the first year of treatment. So it was a double-blind treatment period with patients randomized to patisiran and placebo. And we are able now to show the data at 1 year, but the study is continuing with an open label extension study. So what we observed, the primary endpoint was the 6-minute walk test, and we see that patisiran was able to stop the decrease of 6-minute walk test from 14 meters at 1 year. There are, at that time, just at 1 year, no change in outcome. And there are interesting data about analysis as we observed in Apollo study in the sub-study regarding patients with ATTR hereditary neurologic mutations. So there are other treatments that has been developed. The studies are undergoing. Here is a new siRNA developed by the same company, which is called vutrisiran. The randomized double-blind trial is undergoing, but now we are not speaking about intravenous injection like patisiran. We are speaking about subcutaneous injection every 3 months. So we are, of course, waiting for the result, but we are really moving on this way to decrease the amount of transthyretin production in patients with ATTR cardiac amyloidosis wild type of hereditary. There are also eplontersen that is also undergoing studies called Cardiac Transform, and we hope that we'll have the data soon. And regarding this way of stopping the production of transthyretin, there are also other drugs that are developed in a randomized clinical trial that will start soon, and it's CRISPR-Cas9 developed with the National Amyloid Centers on the company. And it's very interesting. Here we can nearly modify the DNA to stop the production of TTR, and we saw here the production that is stopped. And so we are expecting new data. There are also 2 antibodies that has been developed to decrease the amount of TTR amyloidosis in the heart. So in that way, it's to reactivate the inflammatory way to remove by using the macrophage the amyloid deposits. It's a great hope for the patient if it's worked. And the phase 1 trial had just been published, and it was a double-blind placebo trials. It was a dose escalation study. I tried to go fast, and the results are very amazing. So it was, of course, a phase 1 with a number of patients low, so it needs to be confirmed by a phase 3. But what we observed is really decrease of the amount of TTR amyloidosis fibrils in the heart. You can see the bone scintigraphy. It was confirmed by also the cardiac MRI. And you can see here in this patient with the dose escalation, so how it changed the amount of amyloid deposit, and it's a great hope for the patient if we can confirm that. So I think it's time now to really treat this patient by the appropriate drugs. So for the patient with ATTR amyloidosis with wild type, we have only one drug, Tafamidis. For the patient with the hereditary pattern, we have Tafamidis for the cardiac, of course, infiltration. And for the nerve, we have also patisiran. So it needs to be discussed, of course, with our neurologic colleagues. And it's time now to monitor this patient, because soon I think that we will be able to have different therapeutics and choose the best one for the patient during all along his cardiac amyloidosis story. So now it's clearly time for that. Of course, it's very important, as Sylvia explained, to really diagnose the subtype of amyloidosis, because AL patients need to be treated by chemotherapy or immunotherapy, but not by all these treatments. So if we are not diagnosing correctly the subtypes, of course, the patient will not benefit from the treatment. And so sometimes it's required to go to the biopsies. That's what explains Sylvia. So now it's really time to improve the way we can diagnose this patient, make the diagnosis earlier, and to start appropriate treatment if it's possible, depending on what you have available in your country, of course, in Europe. And thank you very much for your attention.
Thank you very much, Thibault. We see the impressive evolution of the therapies and all this work that is still underway. So this will continue to change during the very near future. Do not hesitate to ask questions and to put questions on the chat. Regarding Tafamidis, what could you say about the stage of the patient? Should we give Tafamidis to nearly all the patients, whatever the stage? What would you say regarding the indications for Tafamidis in cardiac amyloidosis related to transthyretin?
Yeah, thank you, Philippe. Yeah, it's a very good questions, of course. And I think there is two aspects in your question. Is first, how Tafamidis can be beneficial for a patient, and there is also the problem of the cost for of course, of our societies, and how we can manage that at this level. So in France, we have really the luck to have Tafamidis available in all the patients that have a cardiac amyloidosis. So if we have a patient with a positive bone scan, we can start the treatment. Okay, so that's really wonderful, because what we have observed in our center is the earlier we start the treatment, the more we are able to stabilize the disease. So it's really important to start as earlier as possible. But what we observed, and particularly with Sylvia's work, I've just shown a slide, but I really recommend to go to the paper, Sylvia. It's clear that even if you treat your patient that have a late stage of a disease, you can still slow down the disease process and save their lives. Save their life. Every patient is going to die, of course, but you can really slow down the process and earn some time with better quality of life, etc. But of course, if it's too late, you will just slow down the disease. You will not stop the progression of the disease. So, but really, what we observed in our center by treating a lot of patients is that even some patients that were already in worse condition stopped. So, of course, sometimes we decide to not treat the patients, and particularly in patients that are in NYHA4 or that have really a frailty syndrome with not able to walk, etc. We discuss with the patient and we not start the treatment. But even in patients we have one NYHA3, and we can improve really the prognosis of the patients. It's our experience.
And when there is an MRI, quite a lot of late enhancement and fibrosis, sometimes very diffuse. Do you think that this is still possible to give, and it's worthwhile? Are there possibility to decrease the late enhancement, or what do you know? Yeah, so
For the cardiac MRI, I will not say, because we are not able to follow all the patients with cardiac MRI during the time. That's not possible in our center because we have not enough access to the cardiac MRI. So we just do the baseline. So maybe the London team will answer if they have a Tafamidis available. We have a lot of cardiac MRI, but not Tafamidis. But what we observe with the bone scintigraphy is that the patients, some patients, and most of the patients, decrease their amount of cardiac fixation using the bone scintigraphy. So we don't know really what is the bone scintigraphy fixing in the heart, which means that we don't know why there is a cardiac fixation in the heart. It's amazing to use that as a diagnosis, but it's how it works. And so maybe there is a relationship between the amount of cardiac fixation of a bone scintigraphy and the amount of cardiac deposition. And what we observed is that there is a decrease of a bone cardiac fixation. So to reply your answer, I think that even patients that have a strong cardiac fixation can have a decrease of a cardiac fixation, which may be linked to a decrease of a cardiac amyloidosis deposit. So how Tafamidis is able to do that? So I'm sure that maybe it's not Tafamidis. Tafamidis is just about to stabilize the amount of fibrils, maybe to stop the amount of amyloid fibrils that are deposited. But what we observed, and particularly if we look at patients with AL amyloidosis, that are maybe more studied on that, we start treatment that stop the gamma-pathy production at the level of white cells, using chemotherapies, using immunotherapies. But so we are just stopping the production of light chain that stop the amyloid fibril production. And what we observe during the time is that the body is able to decrease the amount of amyloid deposit in the heart. So it's clear that the body is able to clean or to decrease the amount of deposit on the heart. So it's a sort of normal pathophysiologic mechanisms that we have maybe all. Sometimes I think with the aging process, these mechanisms of amyloid deposit cleaning is decreasing. But if we stop the amyloid process, maybe it can clean a certain amount of amyloid deposit in the heart. So it's not enough, of course. So that's why we need maybe antibodies to remove the amyloid deposition in the heart. But I think that in the pathophysiology of a disease, by stopping the amyloid process, whatever the type of amyloidosis, we can improve the heart. But it needs a lot of time, and that's what we saw in AL patients. I still have patients that have been treated by chemotherapy 10 years ago, and they are still improving consultation after consultation the heart. I can see that on decrease of NTproBNP that is going slowly down, but it's a long time process.
Thank you, Thibault. And in line with what you just say, we can remind a very recent report in the New England of about 3 patients who for which the disease disappeared, and the presence of particular antibodies that was detected, that is also suggestive of this possible reversibility, at least in some cases. I have a question about the various incoming new therapies that you describe, RNA interference, antibodies, and so on. What do you think the most promising way, and for which patients? Are there some therapies that could be more efficient for some particular patients? It's very premature probably to say about that, but what is your feeling?
So I totally agree with you. It's an amazing time, and I'm sure that we will have several therapies in ATTR patients with cardiac amyloidosis. So of course, we need to have a result of a phase 3 in a lot of these treatments, but it's a lot of hope for patients. So clearly, the problem with TTR amyloidosis is that we are still diagnosing the patients at the late stage. For not most of them, but for a lot of them, even if we improved, they are at the level generally of heart failure, because you need a certain amount of amyloid deposit to make the diagnosis. And the first symptom that is recognized by cardiologists still now, I think, is heart failure. So for all these patients that have developed symptoms, I think that the best treatment to start will be to remove the amyloid deposition, to stop really the process, and to improve the heart. And then I think that maybe in the future, of course, I don't know yet, we will maybe start by removing the amyloid deposit by an antibody, and then we will stabilize or stop the amyloid process. So it's really what treatment is going to come regarding the genetic silencers or CRISPR-Cas9. Maybe we start everything together, but I'm sure that we will start with antibodies if it works, remove the deposit, and then stabilize or treat the patient by siRNA or by CRISPR-Cas9. If CRISPR-Cas9, works, maybe we can start, and it's just one injection, maybe we start the antibodies and the CRISPR-Cas9 injection, so CRISPR-Cas9 at the same time, of course, maybe. But it's, I think that we will have a sort of stratification depending on the stage of the patient at the time of diagnosis. But what we will maybe face is in each country of the European Union is what treatment do we have, in fact, and which treatment we can afford in each country, and maybe the way we organize our treatment will maybe most depend of what is available due to the cost. And for example, in England, they still not have Tafamidis, and in many European countries also, but they have patisiran. So we will maybe have a lot of discussion with this network to see what we can do and how we can share our experience and etc.
Thank you. There is a question about possible ethical issues regarding the use of CRISPR-Cas9. So what would you say? I think some ethical issues might be related to the use in germinal cells, but in case of the use outside this specific aspect, do you think that there are still some ethical issues at that stage?
Yes, so of course, because we don't know what we are doing really. It's the first time, to my knowledge, that we will use that in patients with cardiac amyloidosis, so we don't know what's going to occur. Of course, CRISPR-Cas9 will be is conceived to go to the liver, but we can't be sure at 100% that it's going to the liver. We have also the history of another drug that has been developed in cardiac amyloidosis, which is called revusiran. That was an siRNA, and at the end, this siRNA was not developed because it increased the mortality. So of course that we need the phase 3 to really see how this treatment can be helpful on efficacy and safety. And I know that these patients are going to be followed for many years after the injection to be sure that nothing happens. So I have not, of course, all the competencies and all of the information about these drugs. It's really new drugs. And of course that there are some ethical issues, but if the patients are really have a good survey, we don't know what's going on with the time, but we are changing the DNA of the patient. So are we fully sure that the DNA mutations will be only in the liver? I can't be sure. So of course that there is some question about that. But it's a great hope because it's just one injection. So we don't know if the DNA is able to repair itself from that. So we don't know if it's will be permanent or not. So, but
okay, thank you very much for all these answers. I think we are just on time, Nienke, so possibly we can close. There is one last question on the chat regarding symptomatic heart failure. What is the role of gliflozin, for example, for these patients? So a quick last question about cardiac management here, if you can answer.
So the problem with heart failure drugs is that we don't have a lot of data, and we don't have randomized trials that are really helping us to understand which drugs we can be used. So it's just only expert consensus that said that beta blockers is not recommended in this patient. ACE inhibitors and secretory valsartan is not also recommended and can eventually alter the patient. And for SGLT2, I think it's a great indication because it has a diuretic effect, of course, and I don't see why we will not be able to treat the patient with cardiac amyloidosis. So we have started, and there are some few studies that has been published. Generally, is monocentric studies, and most of us, it's a patient not randomized that show that it's safe to this patient. So I'm sure that cardiac amyloidosis patient can benefit from this drug, as all over half our patients. Thank you.
So probably we will use more and more also this, this class of drug, yes. So thank you. I think that I would like to thank you, the both of you, experts in that field. So many thanks, and all the attendees for this participation. So thank you very much, and have a good afternoon.
Thank you, Philippe.
Thank you very much to you. Thank you, Nink.
Thank you.
Bye-bye.
Bye to you all.